comentar novamente os que falaram hoje de manhã. Mas acho interessante comentar esse aspecto que a gente vai discutir agora, porque realmente essa fisiopatologia ou patofisiologia, não importa aí a ordem, é muito importante para a gente entender esse mecanismo da sobrecarga de ferro e também essa questão da Associação Americana de Cardiologia, orientando sobre como conduzir a questão do ferro cardíaco, e que também é uma questão que vem sendo colocada muito pelos cardiologistas para o hematologista, é o que significa o ferro alto, a ferritina aumentada, né? E que vem muito aos nossos consultórios. Então, acho que isso é interessante, o debate depois. Dr. Thomas.
Thank you very much. And this, I didn't realize that my talk was going to be set up so well by the endocrinologists. And so I've been thinking a lot about this, this whole topic that apparently everyone has been thinking about. And this talk and the next talk are kind of going to be mixed together a little bit, so I'm sorry for the confusion, but that's the way it is. So just for, a very brief review before we get started here, there's been a lot learned, as you all know, in the last decade about a regulation of iron. And basically, iron is absorbed in the duodenum, and I think one thing that I've really become aware of in the last couple of years, and in my understanding, is it's very important to make a distinction between iron plus 3, which does not react, and iron plus 2, which is toxic and reactive. And it's iron plus 2, or sometimes called labile plasma iron, sometimes called labile cellular iron if it's inside the cell. This is the form of iron which is toxic and causes a damage. And so iron is changed to plus 2 so it can go through the metal transporters, and all the metal transporters like the divalent metal transporter require that the iron be in the plus 2 state. It then goes into the duodenum and is stored in ferritin. Ferritin converts it to Fe plus 3, which is not toxic. And Fe plus 2 exits through ferroportin, and ferroportin is the only iron exporter, and it requires that the iron be plus 2. As soon as the iron goes out, it is converted by a copper enzyme here, hephaestin, and in the plasma, ceruloplasmin, to plus 3, because it's transported on transferrin as Fe plus 3. So transferrin requires the iron to be in the plus 3 state to transport it, and it's non-toxic. When red cells are phagocytosed by the macrophage, the same thing happens. The red cell comes in, it's degraded, the Fe plus 2 is released. It's either stored as ferritin or exported as Fe plus 2 and converted to Fe plus 3 to combine to transferrin. So transferrin transports the iron. This is the usual way iron is delivered. When Fe plus 2 is in the plasma, as labile plasma iron, it can enter the cells through non-regulated non-iron transporters, like DMT1, which wasn't designed for iron, not that I know, I'm not complaining, or or the zinc transporter ZIP14. These were designed, so I'm told, for other ions, not iron. So this is a slide that is courtesy of Dr. Trichta. The iron gets into the plasma, as we see here, and when the transferrin, whoops, what's happening? The iron molecules aren't showing, Fernando. The transferrin molecules aren't showing. All right, so there's supposed to be transferrin molecules pictured here that are bound to the Fe plus 3, and when the transferrin becomes saturated, greater than 50%, the Fe plus, extra Fe plus 3 binds to albumin and citrate, and this is the so-called NTBI. And there is a subfraction of that Fe plus 3, which is in acid situations is converted into a labile plasma iron. And as I mentioned before, this is what's toxic, this is what causes damage, and this is what goes into the endocrine organs. Normal tissues, all tissues have transferrin receptors. Particularly, in fact, the liver has 2 different kinds of transferrin receptors. All tissues have transferrin receptor type 1. When intracellular iron goes up, expression of that receptor is shut down. So you can't become iron overloaded via transferrin receptor type 1. So when I think of iron toxicity, this is a little equation I put together. Sorry, I used to be a physicist when I was a boy, so we think this way. Iron toxicity is tissue iron times time. And this is a really critical concept. It's like what we call crock pots in the United States. They're cookers that cook things over hours and hours and hours and hours and hours, okay? So a long exposure to a small amount of iron could do as much damage as a short exposure to a lot of iron. So this is what I'm really going to be focusing on here, is this time factor here. And this is just my thinking about this, and I'm really going to be interested to see everybody else's thinking about this and see if they think that I'm wrong, because I very well could be. So again, I've mentioned this already. Iron plus 3 is not oxidatively active. Iron plus 3 in ferritin is not oxidatively active. The things that we measure, ferritin is not the dangerous form of iron. It tells us that Fe plus 2 was there in the past. The same way with MRI. MRI does not see labile iron. It does not see ferritin. It only sees big chunks of iron. And John Wood showed this very nicely in a great paper that came out of our early work together, where he looked at the size of the chunks of iron on EM. It's only the big chunks of hemosiderin that are detected by the magnetic resonance imager. So if your MRI shows that you have a lot of iron there, it just means that there are big chunks, physically big chunks that you can see of non-toxic iron. Now I'm sure that by equilibrium kinetics that there is toxic iron next to those big chunks. And there is a relationship between ferritin levels and MRI and damage, but it's still not the dangerous stuff. And I've already said the rest of the words on this slide. The important point is Fe plus 2 is an amplifier of oxidant damage, a powerful amplifier, and it interacts with hydrogen peroxide and Fenton chemistry to produce hydroxyl radicals and singlet oxygen. And these are the most powerful oxidants that are known, at least that I know of. And so the real question that I have here is that we do not know how the long-term effects, what the long-term effects in humans are of transient exposure to free iron or to toxic iron in childhood is. It could be that a 3-month exposure to high levels of Fe plus 2 in a child could cause damage that we will then see 50 years later. We don't know the answer to that question, and that is what has been haunting me as I've been thinking about this over the past couple of years. I mean, my ignorance always haunts me, but this has been at the top of the list. This is data from a paper that we did. Lila Netzley was a postdoc with John Wood, and this is an MRI paper that we published a few years ago. Here you see pituitary iron as a function of age. And these are standard deviation lines here. So look, 5 years of age, 7 years of age, 2 standard deviations above the normal pituitary iron by MRI. So as was mentioned earlier, the pituitary loads very early, and when it's loading through ion transporters, not iron transporters, ion transporters, DMT1, etc. The pancreas, and what I think is so helpful about pancreatic MRI, R2 stars, it's telling us about really iron loading into the endocrine system. And it's kind of like hemoglobin A1C to me. In the transferrin saturation, which reflects the dangerous form of iron, goes up and down within hours. But if it's been up for a long time, you load the endocrine organs and you begin to see accumulation of iron in the pancreas. This tells me that there has been prolonged elevation of the toxic form of iron. Anytime you're loading the heart or the pancreas or the endocrine organs, it means that you have had Fe plus 2 elevation for some prolonged period of time. This is pituitary dysfunction, hypopituitary in red. This is pituitary volume along this axis. These are Z-scores, so these are standard deviations, and this is pituitary iron. So you can see as the pituitary iron goes up and as the anterior pituitary volume shrinks, you get into this zone of functional failure of the pituitary gland. So I want you to remember pituitary early loading, early failure for the last slide that I'm going to talk about in this whole lecture. But what really got me is these patients here. Here are patients that have 2 standard deviation or more below the mean of pituitary volume and hardly any or no detectable iron in the pituitary. So again, I raise this question, does exposure to elevated Fe2 to LPI, because it caused damage that we can't see by MRI or some other thing in the pituitary, and I think the evidence of the damage here may be the shrinkage of the volume of the pituitary. And John tells me in the pancreas he's seeing fat deposition and shrinkage of the pancreas, also with iron damage. And of course we know that when the pituitary, when the IR2 scar is greater than 100, there's a high correlation with glucose metabolism problems. So LPI increases when iron overload occurs, but also when utilization stops. You do not need to be multiply transfused to have elevation in toxic iron. This is data from John Porter and Bradley from a number of years ago in patients with leukemia. And here we see early treatment of myeloid leukemia, non-transferrin bound iron occurs when the reticulocyte count drops. You utilize 25 milligrams, I do, use 25 milligrams of iron a day utilized to make red cells. So you have a big source of iron comes from recycling, much bigger than what's absorbed in your diet. So if you then look at 24 hours after onset of chemo, all these patients have elevated NTBI after their non-transferrin bound iron, after they're blasted with chemo. Here we look at 7 days and 14 days after starting chemo, elevation of non-transferrin bound iron. And remember, a subset of that by inference is this labile plasma iron. This is by shutting off the bone marrow. They haven't been transfused enough to have transfusional iron overload yet. Here's patients, whoops, either this works or it works too well. Again, transferrin saturation versus NTBI. When you hit around 80% transferrin saturation, the iron spills over and your non-transferrin bound iron goes up. This is data from the 2001 bone marrow transplant. Marrow preparation for transplant occurs here on day 3 or 4. Transferrin saturations immediately go up as you kill the bone marrow with chemotherapy. Okay? These patients in this protocol had normal transferrin saturations to start with. They were not iron overloaded to start with. And coincidence with engraftment and recovery of the marrow, these milder chemotherapy treatments, the transferrin saturation drops, whereas the chemotherapy preparative regimens that are more potent or stronger and recovery hasn't occurred continue with high transferrin saturation. What about infusion of iron? This is from the renal literature. Here we give IV iron. This is a lipid malonylaldehyde, a measurement of lipid peroxidation. Not a very good measure, but nonetheless, that's what people have used it. And here you see within minutes of giving IV iron, the transferrin saturation goes up. When the transferrin saturation is exceeded, you have evidence of lipid peroxidation in the plasma. And since I give IV iron, okay, here we go. When you're doing this in the clinic, which we do a fair amount for another population of patients that I take care of, if you infuse the iron too fast and the transferrin saturation exceeds 100%, they flush, they turn red, they develop tachycardia, they get chest pain, and if you don't stop the iron transfusion, their blood pressure drops and they die. We try not to let those things, latter things happen. So acute iron toxicity associated again with free iron. Here's data from Wyszynski, thalassemia, sickle cell disease, equal levels of iron in the liver. But when you look at the toxicity in thalassemia major, much higher. Iron, gonads, growth delay, thyroid, heart, all organs that only load LPI, only load the toxic form of iron. So by the time you see that they're loaded, it means that they're exposed for a long time. So tissue, label iron times time, remember the equation. Sickle cell disease, not the same. Sickle cell disease has effective erythropoiesis. It effectively makes bad hemoglobin. And thal majors have high LPI, and patients with sickle cell disease have low LPI. Again, this is all circumstantial a little bit here, so I'm implying causality by the way I'm talking, but there's work to be done. Again, data from Jensen. Generally speaking, when the transferrin saturation gets over 80%, you begin to see abnormal liver function tests, which is reversible, of course, when you start chelating them. We all know that. This data you've also seen. This is cardiac function in a small group of patients who are placed on continuous infusion desferrol, if I'm not mistaken. This is an older paper. And you see T2 star in the heart is 5.1. That's pretty bad T2 star. Cardiac function, 52% ejection fraction, not so good. After 3 months, T2 star maybe definitely a little bit better, but still very bad. Ejection fraction now normal. So before you've removed substantial iron from the heart, the ejection fraction has improved. 12 months later, T2 star, much better. There's a logarithmic relationship between T2 star and iron. I think everybody knows that. Ejection fraction is normal. So you are binding free iron. And I'll show you in the next talk the data from Porter showing that the minute you turn the chelator on, the LPI drops, like within hours of the time you start it. So chelators bind the toxic form of iron immediately. So it's the free iron that's the problem. LPI is toxic over longer periods, and this was really interesting to me when I started reading about this, so I started looking at the epidemiology literature. And they use transferrin saturation as their primary measure of iron. This is a study of 10,000 patients in the National Epidemiology Follow-Up Study in the United States. If your iron saturation is over 55%, this is your survival. If it's, this is the other way around. So if it's high transferrin saturation, your survival is worse. If it's low transferrin saturation, your survival is better. Okay? The slide is incorrect. 45,000 patients from Denmark. Transferrin saturation, 20, 30%, 40%, 80%, greater than 80%. This is the hazard ratio for early death. This is not thalassemia patients. This is everybody with a high transferrin saturation. What's interesting is the epidemiologists have no idea that transferrin saturation is measuring LPI. But anyway, this is the same data plotted a different way. Again, we see transferrin saturation here just to show the relationship, and this curve to me looks the same as this curve. Transferrin saturation goes up, hazard ratio for early death, all-cause early death goes up with the same dose response. Not proof of causality, but highly suspicious. Again, this is a paper by Chip Manus, who's actually a PhD sociologist, very interesting. He's a really delightful guy. Not to knock social workers at all. He's got 350 publications. Yeah. So, another epidemiology study. This is looking at lipids and ferritin. This is if you have no iron overload and no high lipids, very large VDL, very large lipodensity protein. Here it is if you have iron overload but normal lipids. And here's the survival if you have iron overload and high lipids. Lipid peroxides are well known to be associated with decreased survival. So lipid peroxidation secondary to toxic iron, etc. This is a paper that just came out several months ago from Taiwan, 2,655 patients with thalassemia. Cancer in the abdomen except GU system. Hazard ratio for death, or for cancer rather, compared to the normal population, 1.96. Almost twice the risk of cancer if you have thalassemia. And if you look at hematologic malignancies and leukemia, there's 5 times the risk if you have thalassemia compared to the normal population. But it gets even better. Here we're comparing thalassemia patients on transfusion with those who are not transfused. All-cause cancer, 6.7-fold higher risk of cancer if you have thalassemia and you are being transfused than if you have thalassemia and you are not being transfused. So I am equating being transfused with having exposure to iron. Cancer in the abdomen, all cause, not just liver cancer. We tend to think hepatocellular carcinoma. 9-fold transfused versus non-transfused. And hematologic malignancies, leukemias, 9.3 risk odds ratio for leukemia if you're transfused with thalassemia than if you are not. Again, remember the equation. Iron toxicity times long time. So this is long time exposure. Does increasing iron exposure help? If we treat them, is that going to help? Or is it too late? Well, you've all seen this slide from Modell, so I don't need to present this. We know that chelation has helped our patients with thalassemia. This is the Pharmaki-Berdoukas Greek data. The type 2 diabetes insulin response significantly increased, and in this paper they reduced the iron down to 0.8 to 1.2. So this is substantial, essentially normalization of the liver iron. It's not a huge number of patients, but nonetheless it's dramatic, aggressive iron treatment. 66% of the patients have normal glucose metabolism after this treatment than before. 60% on testosterone replacement, 30% after aggressive reduction of iron. 36% on thyroid replacement, 16% on thyroid replacement afterwards. So it appears that some patients with endocrine damage can have their endocrine problems turned around. I think unlike the heart, where we know we can turn around iron myocardiopathy all the time, I think the endocrine organs, we don't know how long an exposure it takes to cook the endocrine glands. Myelodysplastic syndrome, low risk, on transfusion, become iron overloaded. Decreased transfusion requirement in 64% of the patients when they're chelated. Transfusion independent in 45% of the patients. As you're probably aware, the mechanism of the ineffective erythropoiesis in thalassemia is at least partly substantially related to iron-mediated oxidative-induced apoptosis to late erythroid progenitors. And I think we'll maybe hear about some of this when Antonio talks about how the activin 2 traps work and so forth. I mean, this is now iron-mediated merotoxicity is very real. This is a paper that we did just showing that if you treat MDS patients with chelation, their survival is better. There's several papers out like this. This is the paper that really tipped me over the edge, that made me crazy. Okay? This is a prospective, randomized, controlled study, my dear friend, Dr. Piga. He argues we should do these, I argue we shouldn't, but anyway, okay. 1,200 men, or older adolescents, depending upon how you look at it, were randomized to have phlebotomy or not. The hypothesis was, does iron have an effect on peripheral vascular disease? So these are all men at a veterans hospital, ex-Army guys. In the non-phlebotomy group, the ferritin was 122. Nothing, right? 122. In the phlebotomy group, it's 79.7. Again, nothing. Over a 6-year observation period, there was a 30% reduction in all-cause abdominal cancers. Colon cancer, liver cancer, everything in the abdomen, not just liver. And over the same time period, a 60% reduction in death from cancer, by phlebotomy. This is prospective randomized study. So I think the answer is you may be able to help patients by reducing their iron. So I'm very excited. I think that Dr. Pega talked about this morning. The overall survival of patients with thalassemia is dramatically better, I think, if they follow their chelation. And we expect them to live a long life. So the time part of that equation that I showed is not measured in 5 years or 10 years. It's measured in multiple decades now for children. 20, 30, 40 years exposure to iron. And for childhood cancer, the same way. Our colleagues in bone marrow transplant and our colleagues in pediatric oncology are oblivious to this. We've seen many consults of patients that are in heart failure with transferrin saturations of 100%, and they don't even think to check. We just had a paper that came out just this week in pediatrics of a leukemia patient treated 1 year. 1 year from diagnosis with a T2 star of 15. So there's something different about cancer patients than there is thalassemia. They're not identical. And that equation, environmental factors, is a factor we stuck in there, while having leukemia and getting chemotherapy, I think, is an environmental factor, perhaps. 66% of patients with pediatric cancer had iron overload at 1 and 2 years after their onset of their therapy. So I don't know what the real incidence of that is in pediatric cancer, but it exists. From the Children's Cancer Group in the United States, a survivorship study, 1,700 patients that had childhood cancer. 21% by age 50 have evidence of cardiomyopathy. And now back to the pituitary question. 76% have evidence of pituitary dysfunction by age 50. Not a single word. When you search that PDF file, the word iron or the letters FE do not come up. This is a study of 25,000 patients from a radiation oncology journal where they looked at relative risk of second malignancy. Radiation alone was their denominator. That was their common thing. Chemotherapy alone, 9 times higher risk of having a second cancer. Chemo plus radiation, 29 times increased risk of second malignancy. So apparently when you give chemotherapy and you shut off the marrow and you rise the LPI levels very high, and then you hit them with ionizing radiation, you might increase the risk of cancer. Neither of those articles talk at all. So I think many of us here are treating cancer in kids and in adults. We have multiple things on our job list. I think we need to begin to take what we know about thalassemia and transfer it. So, because we can't predict what the exposure required, and the subsequent consequences are these multiple years later, what we are doing in our group is we are trying to normalize the liver iron. And many of you know Dr. Berdukas. We had the great pleasure of having him with us for 5 years in Los Angeles. I thought I was being aggressive at keeping the iron level less than 2. When he arrived, he announced that 0.85 was the proper target. I don't know. But probably 30 or 40% of our patients have liver irons less than 2. And we have relatively little problems. The thing is here is you need to know how to use chelators, and you need to be able to accurately monitor the iron by MRI, or you shouldn't try to do this or you'll get into big, big trouble. And I think that we need to take what we know about thalassemia and apply it to other areas. So with that, I thank you for your attention.
Bom, maravilhosa apresentação, wonderful presentation. Eu queria fazer uma pergunta em português. Uma pergunta. Esse ferro tóxico dessas pessoas que no NANES, no estudo do NANES foi apresentado aí, de onde vem esse ferro tóxico? Da alimentação? Porque foram pessoas sadias que não tomavam transfusão, que não faziam uso, provavelmente, de ferro como tratamento, De onde vinha esse ferro tóxico que fizeram que as pessoas tivessem mais risco de câncer porque tinham saturação da transferrina mais alta?
Well, in this data, some of these patients have hemochromatosis, the epidemiology data. Some of them have MDS. There's all kinds of different, so if you exceed the ability of transferrin to bind that extra iron, whether it's because you turn off the bone marrow, like an aplastic anemia, myelodysplastic syndrome, Diamond-Blackfan has very high levels. Diamond-Blackfan is it's a person's name. Yeah, they know what it is. Has very high levels of iron, of free iron, because the marrow is shut off. Yeah, I mean 25. Yeah, if you shut the marrow off, it's like giving yourself 25 milligrams of iron a day. Yeah. And not in the form of, black sausage or...
Okay. Alguma pergunta mais? Quem tem algum comentário?
Just one thing, I'm not sure that the ferritin levels that we consider normal are actually safe.
So the ferritin levels that we consider normal are not safe. In my next talk, I'm going to show that data. We have patients that have ferritins of 500 and liver irons of 6. We have patients with ferritins of 2,000 and liver irons of 3. So ferritin is a terrible marker. It's easy to use. It's not useless. As I'll show you later, 25% of the time when ferritin is going up, total body iron is going down.
Okay, vou fazer em português a pergunta. Assim, nós conversamos sobre isso já no almoço, mas eu queria aprofundar um pouco mais. Nós temos recebido na clínica de adulto pacientes que são encaminhados com 600 de ferritina, 700, 800 de ferritina, com ferro sérico também alto, mas com saturação abaixo de 55, correto? E até onde eu tenho informação, não existe nenhum estudo mostrando que a longo prazo isso levaria a algum risco. E você coloca aí muito bem que não só o tempo, não só o valor, mas o tempo de exposição, isso pode ser no futuro aumentar a chance de câncer hepático, mesmo em população normal. Então eu queria que você falasse alguma coisa sobre isso. Se é correta, eu às vezes tomo a conduta de não fazer nada, oriento dieta, mas não faço flebotomia, porque a saturação é normal. Isso é correto, não é correto?
Yeah. So, measuring the...
General patient,
Yes,
okay, no thalassemia.
Yeah, okay. So, the iron that we really want to have an idea about is the LPI. Let me give you an example. I have a child that has a transferrin saturation of 5%. I thought she had iron-resistant iron deficiency anemia. I gave her a single 325 milligram tablet of ferrous sulfate and repeated her iron studies 90 minutes later to see if she could absorb iron. Her transferrin saturation was 90%, and it was 10% the next day. So transferrin saturation and probably the direct measurements of LPI that we're now setting up by Kabanchek's method, is, in my mind, it's like glucose for diabetics. A single measurement of a high glucose doesn't mean that you're in trouble. It depends on the conditions under which it was drawn. Your patient may have taken an iron vitamin in the morning before they had the lab test done. Okay? So what we want is what we call, I don't know, in Portuguese, the same thing, area under the curve. We want the area under the curve, transferrin saturation, or LPI. I think that the pancreatic iron by MRI, in my mind, gives us some idea about that. Because it only can go in if you have the +2 iron. But we don't have a perfect way to look at this. It's a problem. And in these epidemiology studies, these aren't serial measurements that they're making. I think some of them had to have an elevated level on more than one measurement. But with 45,000 patients, sampling, statistical sampling fixes it.
To come back to transferrin saturation and cancer in general population on thalassemia and cardiovascular disease. That is very true what you showed, but there are also papers that investigated the possibility that the transferrin saturation is representing also some lifestyle habits that predispose to cancer, gut cancer, because mainly in males, mainly in certain cultures, what happens that you have a meat-rich diet with grilled meat, cooked diet. So you have a trend to have some more iron. Transferrin saturation is around 40, 50, and so. And so you have more cardiovascular disease, you have more cancer. The trend is very clear in all the studies, but it's the transferrin saturation, it's the liver iron concentration and tissue iron that is slightly more and so predisposing to cancer, or it's the habit that is the other environmental factors. This is not just to say that transferrin, I strongly believe in transferrin saturation, but we have also other things that are together with this,
Well,
and we have to take in mind.
Yeah, and that's what Chip Maness tried to look at when he looked at the iron loading and the plasma lipids in the combination before. So this is absolutely true. What I'm saying here is I think that we should all, what's the action that we should take when we treat our patients? We should really worry about this, number one, and try to figure out how to sort it out. We've been measuring now transferrin saturation in our transfusion population. One thing is if somebody has a liver iron of 20, and their transferrin saturation is 30 when they come to clinic, they took their XJade or their chelator a few hours before the blood test was done. So it might be a marker for adherence. And we're now having them hold their chelator for a day. Transferrin saturation measurement itself is imperfect, okay? And we are more confused than ever looking at the data. So we need to do more research, we need to do more studies together.